So for those who don't know, Dr. Reena Karani, she has many titles which we'll have to hear. She's a senior associate dean for undergraduate medical education. Does a lot for education here. I'm really glad she's here to talk to you guys today about turning your educational work into scholarship.
Thank you, Andy. So I'm really happy to be here, and I thought maybe it would be great if you could go around and tell me your names and what year you are.
I'm Eric. I'm a second year.
I'm John, I'm second year.
Steve, also second.
Well, welcome. Thank you for having me. And we're going to spend some time thinking about how you turn your education work into scholarship. And I think this might be one of those topics where we think about sort of why we even talk about, the strag, welcome, Dr. Welcome, Dr. Trump. We were just going around talking about being here in timely fashion. So I want to really thank Dr. Leitner, with whom I give this talk at the Harvard Macy program, and it gives me this shameless way of promoting a program for those of you who are interested in education as a career and leadership in education as a career. Every year, Sinai, Boston Children's, Partners Healthcare International, and the Harvard Macy Institute run a program for residents and fellows who are interested in becoming leaders in education. And the program runs over a weekend in December in Boston itself, and usually is attended between 45 and 60 house staff from around the country. And it really focuses on bringing a project that's of interest to you and interest to your institution, and sort of workshopping that project through to a point where you can then go back home and work on it and continue to do it, but also really building skills in sort of formally thinking about leadership, career advancement, looking at some real sort of key articles in medical education. And Professor Coyle here was a participant now as a faculty member for us there. So I really urge you to think about applying for that program. For those of you who have another year here next year or have time, I think we have the dates as December 12th this coming year. Andy can tell you a lot more about it, and we'll be happy to send out the program brochure when it comes out, but it goes out to all house staff here. And each year we have between 9 and 12 people from the health system who come. So let's talk about, what we'll learn by the end of the session. You guys have had a session a while ago, again in the fall, talking about measurable objectives. I hope that by the end you will appreciate the characteristics of scholarship, begin to think about evaluating your own project ideas through Glassick and Beckman's criteria. Think about practical ways to become scholars yourself, productive education scholars yourself, and consider where you might produce, publish, disseminate your work in medical education. So I'd begin by sort of thinking about why do you want to disseminate your work? Why do you want to turn your work into scholarship? What might be some of the reasons that we want to do that?
If you find something really great, then you're not just educating your own medical school, but other medical schools.
Totally, to share information so that other people can adopt those practices. What else?
More selfish notion. Take credit for your ideas and to actually be able to show that you've been working on something in a constructive fashion.
Absolutely, and that is like documentation of the work you're doing, and also for this idea that very soon many and all of you will be probably members of an academic community, and for your promotion you will be asked to show that you can perform and produce and contribute to the academic sphere through scholarship activities. Why else might we want to share our work in education?
So you also might get feedback from the places that you weren't expecting it, or people building on it.
It's totally right. I mean, we think of that in science, and when we really look at reading journal club articles and think about how things move something forward. So one is that it puts it out there for other people to reflect on and sort of critique, if you will, but it also then moves the field, potentially to move the field forward. So absolutely. So those are great reasons to think about this. We want to disseminate new knowledge. If we have a best practice approach, we really want to put that out there. You want to create new questions, because that's actually one of the most stimulating parts of being an educator and being a scholarly educator, is this concept of really thinking about what's the next question I have in that area for you to advance in academics. And finally, to think about the sort of ultimate reason we do medical education work, which is to kind of care and improve the health of our patients. So, if we go back, I want to give you some sort of background about kind of where we, how we've come to where we are today. So Ernest Boyer was an American educator, and in 1990 he became president of the Carnegie Foundation for the Advancement of Teaching. And this foundation really spent a lot of time in those decades after Boyer thinking about the professoriate as it relates to educators, right? There's all this stuff about professors of every other field, but really in the concept of education. And he said that we have to reframe the roles, the expectations, how do we recognize and advance educators using a framework. Instead of saying, well, it's just sort of wishy-washy, we kind of know what they do, we kind of know how to measure their success. But he said, no, we need to come up with a formal way to really recognize and sort of classify their roles. And he proposed this expanded 4-category definition of scholarship. And the 4 categories for him were the scholarship of discovery, which is, if you will, very traditional experimental research. The scholarship of application, in the concept of building bridges in the way of sort of harnessing knowledge in a very useful and practical way. The scholarship of integration, which often referred to as sort of making connections across disciplines, or showing the relationships of parts to a whole. That's another way of thinking about integration as he referred to it. And then the scholarship of teaching, which is how does one as an educator communicate to learners such that they develop enduring learning and deep learning. That concept became his 4th category. So this is the way he defined the 4 categories of scholarship. After his tenure at the Carnegie Foundation, Charles Glassick became the president. And he said, I buy the fact that we have to broaden the definition of scholarship and think about the roles and expectations of educators. But at the same time, if we do that and we have those 4 categories of scholarship, we have to be able to have a reliable, feasible, valid way of judging the quality of the work that we do in those 4 areas. And so he said, we're going to judge the scholarship using a language, a common set of criteria. And the criteria he proposed were that your scholarship had to have clear goals, that you thought about the preparation, and we'll talk about that in a sort of different way in terms of the language, that you used appropriate methods to measure your question and your scholarship, that you talked about significant results, that you effectively presented those results, and that you engaged in a process of reflection to think about the next steps and where you'd go forward. So he said, we're going to judge scholarship using these criteria. So if we go back, if you will, to that 4th category, that 4th bucket of scholarship, which Boyer had put out, right, this concept of the scholarship of teaching, which is communicating effectively to learners to have enduring learning and long-lasting learning, then how would that map out? When you think of the criteria that Glassick proposed, which is on the left, then how does that apply to that bucket of scholarship of teaching? So now you guys with Helen did review the differences between goals and objectives, and in the very traditional teaching sense, there are very clear differences between goals and objectives. For the scholarship of teaching, the concept of clear goals is to actually have your teaching grounded in providing objectives. There's a rationale, there's a clear map of measurable things that relate to your teaching. That their preparation means that your scholarship is grounded in what is known, that there's a conceptual framework, that it's grounded in the previous literature. It's not just some hypothesis that you came up with, but your hypothesis was grounded in something that was previously known, or you were advancing concepts that you had read about or learned about. That your methods for scholarship are aligned with your objectives, that they're congruent with the objectives. So if you were teaching someone a skill, you're not, for example, going to use a PowerPoint presentation to teach them that skill, right? You might use demonstration as an effective method. So how congruently aligned are your methods to what your objectives are? What are your outcomes that you are defining? What are you going to measure as a result of your work? How are you going to disseminate it in terms of the presentation? Have you taken your work and pushed it out there to get feedback, to get the critical eye, to get the next steps? And then how do you use what you get back from your peers to revise and critically appraise and rework your work? So you will see these 6 sort of criteria used as you put your work forward in education. Many times when you submit an abstract, you will get back feedback that actually follows these 6 criteria. They're looking for these sort of aspects of your work, even if the abstract follows the very traditional, sort of aim, methods, results, etc. The educator eye will be looking for this. And that's because it all comes from this Glassix criteria. So the third sort of president at Carnegie was Lee Shulman, and he said that he wanted to think about sort of what is scholarship? Like, is there a simple way to think of what scholarship is? And he said the 3 Ps were sort of the way he looked at it. He said that scholarship has to be a product that can be reproduced and built upon, that you put it out there and are open to a peer review process of that product, and that you publicly disseminate it. The 3 Ps were really what he defined as scholarship in whatever arena it was that you were talking about. So you might say, well, you know, what's the difference between scholarly teaching, right, taking a scholarly approach to teaching people, and the scholarship of teaching? And that's where Lee Shulman's definition comes in. You can take a very scholarly approach to teaching someone that's based on adult learning principles, that's thinking about how to align that with what they're learning, if it's a skill or an attitude. You can think of principles of engagement. You're thinking of Kolb cycle. You can take a very scholarly approach to teaching. And that is different than the scholarship of teaching, where you're really producing a product, you're publicly disseminating it, and you're putting it out there for peer review. So that's one of the sort of things that I want to make sure you guys got. What's the difference between scholarly teaching and the scholarship of teaching? So, you know, taking that from the sort of background of where we got, how we got to where we are today, is this concept of how do you take something that's an idea you have or project you're building and thinking about moving it into the scholarship arena. And David Cook and Tom Beckman at Mayo have this great article that's cited on the slide that I would urge you to look at. It's a really sort of simple and cool article, but they talk about a 3-step approach to thinking about a scholarly project. And the first is, as we think about in all research, this concept of what's your research question. And the clarity of your research question and the specificity of your research question will certainly help in many ways make your project clearer to you. If it's a complex, convoluted, hard to understand question, then everything following it will suffer. Your design will suffer, your outcomes will suffer, your interpretation will suffer. So really spending time to formulate what you would consider your research question. And your research question does not have to be something deep. In education, the beauty of it is that we're always engaged in it. We're engaged in it every day as trainees like yourselves. You'll be educators when you graduate from your residency and fellowship programs. And I always say that it's amazing just to think about what's going on in your educational life right now. What changes have been implemented in your program, right? What's the evidence to support a method of teaching currently? Or a change in sort of structure in your residency programs, or a change in how you see patients in your practice, or the way patients are triaged from an emergency room to a hospice service versus a house staff service, or bedside rounds conducted in manner A versus manner B. Right? There's so many things that happen in your day-to-day life that you might have a question about. And jotting those questions down in whatever way you can was one of the best tips I got from one of my mentors, which was this idea that if you sort of say, oh, I've got that question and I'm just going to wait and I'll put it down later, you're going to forget it. So figuring out if it's your smartphone or if it's a book you carry or something where you just jot down questions that come up to you about the simple things that you're engaged in every single day will give you fodder for your scholarship. What data do you have access to? We collect reams of data, like things as mundane as resident schedules and resident performance, or patient, points of entry and exit, or medications, or discharge summaries. We have reams of data, and we do not look at those data. So if something catches your fancy, it can come from everyday life, and it can become an area of scholarship for you. And then you want to look at the literature. So you might come up with your question. You might say, well, this is really just stimulating to me. And I'm actually going to go back to the literature and see, maybe it's already answered. Maybe there's a ton of stuff out there. Or maybe there's nothing out there, and we're just doing this because it was convenient, or it was easy, or we didn't really think about it, or just try to solve another problem by doing this. Look at the literature. It's hard to do that when you're a resident and you're so busy. The library at Sinai has an incredible amount of resources here for those of you who haven't used it. You can approach an informaticist at the library who will help you with your lit search. They will tailor their lit search based on stuff that they might have a communication with you about. They will come to you with a summary. There's really, really good resources here that we tend not to use. So when you get freaked out by doing the lit review, do not, because the library here has some really great support for that. And then you want to kind of refine your question. You want your question, as I was mentioning, to be very, very specific and clear. So that someone else looking at it, a peer looking at it, a mentor looking at it, says, I know what you're trying to ask here. And so one sort of acronym that's often used is your question finer, meaning is it F feasible? Is it interesting? Is it something that's novel? Is it ethical? And is it relevant? Right? So if something that you're going to test has like a problem with how you would distribute a sort of a limited resource to a learner, that might not be ethical, because maybe I can get by the IRB by saying only some residents would get it or some students would get it and the others wouldn't. So you want to take your question and really sort of poke at it and say, is it feasible? Is it interesting? Is it novel? Is it ethical? And is it relevant? Right? And that's just a tip to kind of sort of help you take a question that you have that starts off as something you just jot down very quickly and move it into this phase where it's something that I can then look at the literature about and I can really sort of study. So step 2 by Beckman and Cook was to think about your design and your methods. Once you have the research question, now I'm sort of going to build on my sort of the study design and the methods I'm going to use. And you're going to go through a sort of thoughtful process. Is it an experimental study? Is it a study where I'm going to manipulate, right, variables and see the impact, manipulate independent variables and see the impact on a dependent variable? Is it a traditional experimental design? Is it an observational study where I won't be manipulating variables, but I'm going to study the relationship between variables? So I'm not manipulating anything, but I'm looking at how they sort of relate. Or is it a validity study? Am I gathering evidence that will help support the interpretation of data? So that we take in training exams, we make inferences about them. Are those inferences supported by all the different types of evidence? Like, how do I gather that evidence to support the meaningful interpretation of data? Is it a qualitative study? Am I studying something pretty complex? It's a complex phenomenon, and I'm really interested in hypothesis generation. I don't know how to explain that complex phenomenon, and I'm actually interested in what the hypotheses might be. Maybe I want to study the phenomenon of what happens exactly in one report that makes it such a high-quality learning experience for those there. What is it about it? Is it the interaction among peers? Is it the way the case is presented? Is it the fact that it's temporally related to something that's unknown because the case just got admitted? What is it about a complex phenomenon? What is it about bedside rounds? Might feel very welcoming to a patient or not, right? What are those, the phenomena that are complex are often best understood through qualitative methods. Or is it a systematic review? I'm very interested in the fact that residency clinics have moved from, like, you know, where you leave the ward to block formats, but, you know, what's the evidence out there to support that? Is it 2x4 block? Is it a 4-4? Like, what's the evidence out there? Am I going to summarize the literature in an area in a systematic way to make an inference? So the design and methods in these broad categories and buckets become very, very helpful once you have that very formal research question. And then the third step is to think about what the outcomes are that you're going to measure. And if you think of sort of outcomes, we tend to use the language of Donald Kirkpatrick, who proposed this 4-stage hierarchy of outcomes. And what he proposed is that educational work, we tend to first say we measure reaction, right, which is satisfaction and preference. You know, you guys will tell Dr. Thomas and Dr. Coyle, we kind of like those sessions. They made me feel warm and fuzzy. I felt like I could do that. I really am glad I chose the medical education track. That's level 1 outcomes. Very common. God knows how many, you know, sort of sessions you've been through in your careers already where they just ask you to rate, like, whether you enjoyed it and liked it. That's level 1. Did they like it? Level 2, did they learn it? And that is the impact of your work on their knowledge, skills, and attitudes. Right? And you probably talked about knowledge, skills, and attitudes when you're thinking of objectives. This concept of, if I was teaching them a skill, did they learn the skill? If I was trying to change their attitudes towards something, did it really change? Do they know more about a topic than when we started? And that's, did they learn it? That's a second level after sort of reaction and satisfaction. The third level is the impact on behavior. Does it change their clinical practice? So does it really have a meaningful effect on what we would consider kind of important, right? So did they use it, essentially? And then the top of the pyramid is what's the bottom line? Did it really have the impact on the bottom line? Did it impact patients? Now, what's really interesting about this pyramid is the meaningfulness of the outcomes goes higher and higher as you move up, correct? I mean, for sure, we can all say that if I liked it, but it didn't really change my practice, maybe it's not that important. It's something that really changed my practice. But as you move up the pyramid, what also happens is it becomes harder and harder to measure. And that's because the number of confounders goes higher and higher and higher as you move up this pyramid. And as the confounders go up, any causality that you can make from, it's the result of my educational intervention that the length of stay went down, becomes harder to defend because the number of confounders in there has gone up. So the effect size as you go up this pyramid goes way down. And when your effect size goes down, right, we know what we have to do, which is you have to increase your sample size. And you have to increase your sample size so much to get results that are higher and higher up on this pyramid. So in education research, there's a common theme that you'll hear people say, well, they're not really measuring patient outcomes. It's considered the holy grail of education research. But we also know that that is not necessarily true, because there's so many confounders: time, program changes, patient variables, institutional variables. There's so many confounders that whether or not I can say that something I did A caused this massive change, B in a defensible manner, really is not accurate. But sort of pushing yourself to going above reaction in the design of your scholarship is really key. I really push you to think about how you can measure learning and or behavior if you can. So sort of bottom line on this slide is, as you think about your outcomes, you have to balance meaningfulness with feasibility. So you have to think about that long and hard when you pick what outcomes you're going to do when you think about your education scholarship. So that's the third step. So what we want you to do is to think about your own either educational project that you've thought about or that you have an idea for or that comes to mind right now. And I'm going to pass around a small worksheet. And what I'd like you to do, it contains exactly the steps that we talked about. And I want you to think about filling in that sheet for 10 minutes quietly on your own. And then to work in pairs to present your project to the person you're working with for their feedback and input, thinking about these very areas that we talked about. Questions about that? Mm-hmm. I think I have enough. We're good? Oh, perfect. All right. Time. 28. Give me a time. Oh, that Thomas is going to fill. He's going to fill one in there. Oh.
go back to the pyramid.
Sure. Sure. I can keep that up for you guys. Probably another 2 minutes of work solo, and then we'll have you work with a partner to share and get feedback and think about questions. You guys almost done? Perfect. So whenever you're done, you can just pair up. There's even numbers. Perfect. You guys will pair up? Perfect. So start your project. It would be great to kind of think about giving other feedback.
Yeah, we should split up.
Yeah, you guys need to split up.
Because we're working on
Oh yeah, so yeah, totally split up. Does anyone want to do a little shift?
Yeah.
Yeah.
Come on over.
Colin coming over.
You guys are doing.
So, we are doing basically a sort of physical exam curriculum of residents can use to teach their med students something words, something that's a little more sort of bylaws and creates certain like targets they should try and hit, like, for
How many
example,
total usually?
you know, identify like one page with like backgrounds, like low bar consolidations and shit. Because we really find that a lot of them sort of don't know how to take care of this good exam.
And all PUA twos and
Start
threes.
applying it to exams. So that's what we're doing. What about you?
So, I'm still thinking about this project and having a hard time, fully
And then they
working on
put
it. I would really like to have residents, so take the idea kind of.
Amazing. And then they have one more?
A lot more fun.
Yeah.
But taking that back to a resident-driven. And
Right.
resident-run
And there-
board is like a safe place for the residents to review things that they're either still dealing with, still thinking about, what you could have done. Kind of thinking of that process of self-reflection, whether that would promote people to review more of their cases and cases. To learn what they don't.
Did we
Or
publish
whether
on
that
him?
just helps like with the stress burnout kind of thing.
Every other
Like finally thinking about it. It's just, might help or, I don't know.
So I think that's a couple of missions. So that would be like a significant thing, like QI,
7.
like probably what we do would be like more resident only.
Exactly, just the residents there. It would be kind of structured, there'd be a structure, you would ask someone to kind of think about the case that still bothers them or the decision that still bothers them and to reflect on that and kind of flush it out. But residents would follow along. Residents would be encouraged to ask questions and think about it, but beyond that, just some of the flushing
It's
out.
actually, yeah, so
like were there areas you felt like were tough to kind of consider as you build your scholarship? Piece of cake. These two are, they're gonna watch your projects, these two.
Actually live.
Say more, tell me more.
So we were talking about, one thing that we both mentioned was like how comfortable people are about something. And so we were discussing where would that actually, like, is that an attitude or actually really kind of
Oh, that's a great question. It's like if you're measuring someone's comfort with either a self-reported comfort in doing something, like where would that fall on Kirkpatrick? And the general sort of approach would be it would fall into that reaction level. And that's because there's some data to suggest that our comfort doesn't correlate with our actual skill. Just like there's this stuff that's emerging about our self, a sense of self-efficacy, that people who are poor performers tend to overrate themselves, and people who are very high performers tend to underrate themselves, so that our general sense of what we think our efficacy is or our comfort is does not correlate with our actual sort of measured skill. And that's one of the big areas where you will see, like, we'll talk a little bit about, sort of roles you can sort of think about your scholarship for, but I think one of the things you can expect to hear from someone when you're presenting your work or your design to someone is someone might say, well, that's really great that you're assessing their comfort with something, but is there a way for us to actually measure their skill? Or should we measure both? Let's assess their sort of self-reported comfort and then let's test them. Let's put them into a testing environment where we can actually see if that really matches up for that particular skill or that particular area. What other questions? What other things came up?
That's like exactly the question that I had. In trying to choose outcomes. So like looking at like residents as teachers and how to evaluate being observed and getting feedback, and how that ideally would be how that improves when your effectiveness as a teacher.
Right.
How to measure that, whether it's interns that you teach or medical students, but that's a little bit harder to measure than your comfort level as a teacher after being observed. So
that's a great, and resident as teacher, the whole sort of idea of those curricula used to have a bunch of studies that looked at sort of self-reported sort of skill after going through a program that taught you that. And then, so there's, have you heard of OSTEs? You guys have heard of OSCEs, right? Because you all did them. God knows you did them. So OSTEs are objective structured teaching evaluations or exams, if you want to really push that word, where you have a standardized learner. It's really interesting. So you would train an SP or a student to play the role of a learner, and then someone who's been to a resident as teacher course would actually deliver something or have to do something, and then that person gives them very structured feedback based on a rubric. And that might be pushing that assessment from the reaction comfort to actually measuring their skills, albeit in a simulated environment in some ways. And then you're right, that you could push it to like impact on learners would be a great way to think about it, moving it up, where they're actually giving you feedback on that person itself in particular domains that relate to what you develop. What other questions? Any other questions?
Yeah, one thing we were talking about is I would find that really valuable is Rachel's idea of having a peer resident observing teaching.
Yes.
But then it's the outcome is probably a reaction outcome, like, oh, I liked that. So it would still be, I think, in my mind, like a valuable thing, although it's low on the
Exactly.
scale. So, like,
And you're right, it might be valuable to the actual person, and it might be formative in that way. That if I got direct feedback based on someone's observations of me, that would be really personally very helpful, because we actually don't get observed. And so we don't get feedback that would be really meaningful to us. And yes, so one of the ways you could sell that if you were developing your scholarship agenda is that you'd been, one of the outcomes is the feedback to the, let's say in this case, it's the index trainee who's done the resident as trainer, so that they're getting individualized feedback. And yes, it's a reaction level, but you are actually giving them feedback, and you might even assess what they've done with the feedback or how they're going to incorporate that into their future practice. But direct observation is a really helpful way of assessing some things. There's some good direct observation tools that can be used, so you're not just saying, did the person appear to be teaching well? Did the learner appear engaged? You want to try and think about, when you're thinking of your outcomes, it's like, are there any tools out there that are already validated that you could use? Because then you're using a sort of format of asking questions that then can be, that has some valence to someone else reading that scholarship piece, that manuscript. Any other questions? Right. So, how do you disseminate your scholarship? It's a topic we talk about a lot in medical education when you move into the attending phase of your career. And that's because there's a lot of value placed on dissemination of your work in the academic environment in particular. There are ways to present that relate to putting together a poster, to developing an oral presentation, or actually conducting a workshop. Let's say you've developed a whole resident as teacher curriculum and you actually want to do a train the trainer for other people interested in building that. You might say, we'll do a workshop at a meeting so that people can come and learn how you actually did it and then implement it at their own institution. And those in the presentation world, if you will, there's not that much of a hierarchy except to say that posters have sort of the lowest sort of value as a start, and then orals have more impact. They're perceived to be harder to get. And then workshops are really in a different bucket because you often have to apply well in advance, and it's not like you're sharing data necessarily, you're sharing technique and style and approach. In terms of publications, there's so many ways in medical education to publish. There's web-based and media resource materials that people can access. I'll show you an example. You can develop actual curricula or assessment methods. I see you developed an OSCE that has a checklist, and you can do that, or you develop an OSCE station, or you develop a survey to measure a certain behavior. You can put those out there, and that becomes a dissemination model that other people can use and test and validate your work. You can write book chapters. There's opportunities for editorials and opinion pieces, and of course, sort of the kind of pinnacle of stuff is this concept of putting manuscripts together for academic journals. So where do you present your work? There's just tons and tons of organizations that you can present at. This is a very, very short list. The Association of American Medical Colleges tends to focus much more on undergraduate medical education work, and that can be broadly defined as things that are curricular or student life, student health, student mental health assessment, and then a very formal category within the AAMC is called RIME, the Research in Medical Education, which is very formal medical education research projects. The ACGME has a national meeting of its own. It's smaller than the AAMC meeting. It focuses, of course, on GME, but is actually a pretty low-hanging fruit to get into. They don't often have a lot of people who are kind of banging the doors down to go to that national meeting, and yet if you are interested in sort of GME as a career for yourself, then getting into the ACGME meeting is a really good way to meet other people who are educators interested in GME. And it's a small enough meeting where you'll meet a bunch of people, it's easier to get into, and then you're with like-minded folks who might have the same interests as you. Their big, of course, focus, as you can imagine, is really the sort of scholarship now around milestones and EPAs. They're like obsessed with it. If you have anything in that area, they will just accept you quickly to the meeting and be on a working group very, very quickly. The ACCME for continuing medical education, the concept of sort of after you finished your training and you move into sort of the metrics of how people measure your continued professional development. ACCME has a meeting. There's so much discussion, as you know, endless discussion about maintenance of certification in our field in medicine and now spreading like wildfire to other fields. And the concept of how does CME, which has largely been sort of based in large conference centers with us kind of napping and getting credit for it, but how are we actually going to tie what we learn to some things that are important on the top of that pyramid, or how do we push ourselves to be more accountable, that we actually sort of take what we learn there and actually take care of patients better. The Behavioral Science in Medical, ABSME is the Association of Behavioral Science in Medical Education. They're quite interdisciplinary and are very interested in sort of behavioral science interventions with patients, maybe related to behavior change, the much more sort of complex phenomena around caring for patients, the bioethics of stuff like that. So that's a good organization. The Association for Medical Education of Europe is it brings together the spread from undergraduate, graduate, and CME, very much focused in Europe, but brings together people from South Asia, Asia, the Middle East, all the way from the US, a kind of great meeting to go to, and also a very prestigious meeting to get into. The National Board of Medical Examiners, you all remember fondly, but the NBME is very, very interested in assessment tools. So different ways of assessing very complex behaviors like communication and interpersonal skills, or behavior change and lifestyle modification. How would one assess that in like reliable and valid ways? The Ottawa conference is sort of the premier assessment meeting. It's held every 4 years, so it's massive. It's just thousands of people, and it brings together everyone who's obsessed with assessment and evaluation. They're not interested in sort of the curricular part and anything else. They're obsessed with evaluation, and it'll bring together not just sort of medical educators like us, but it brings together, psychometricians and statisticians and, sort of like the real wonks who are obsessed with assessment. It's a great meeting. And then your specialty societies. I cannot say enough. This is like, we don't think about this enough. Like right before you even differentiate into your fellowship careers, there are organizations in our specialty of medicine that have incredible educator opportunities like SGIM. So some of you have been or will go to SGIM, the Society of General Internal Medicine, has incredible portfolio of activities for those interested in education, all the way from residents and medical students interested in it to young junior attendings and beyond. And they have 100 opportunities not only for you to kind of develop some skills through workshops and formal programs, but to kind of presenting your education work in oral abstract form, workshops and poster presentations. So it's a very good meeting to try and aspire to take the projects you're going to develop here, even if it's just the beginning to a needs assessment, if that's step one for you, which was that first part you learned with Helen talking about Curran's approach. It's a 6-step approach, that concept of what's the general needs assessment I have to do that sort of tells me that I need to develop something. You can present your needs assessment at SGIM and get great feedback. So it's a very good organization to think about. If you're interested in GI or nephrology, or every one of those specialty organizations has an education either arm or committee or group interested in residence training in that area or fellow training in that area. It's literally a matter of just looking and reaching out to someone there, because folks will really sort of welcome other colleagues into that arena if you have that as an interest. So the specialty societies are really great ways to think about. Just one plug for another program for those of you very interested in teaching skills, not sort of all the sort of other stuff. SGIM has a program called Teach, which is training educators across the continuum of healthcare. That's the day before the SGIM conference begins, and it brings about 25 to 30 people with a focus really on teaching skills like active feedback, sort of the concepts of really building a teaching portfolio. It's a great program. If you have the chance to attend that meeting, to really build that in. And it's a certificate program, so it's something you can put on your CV when you're applying for your jobs in education. So that's presenting. Publishing, tons of stuff. There are tons of big journals that are out there. The sort of holy grail of medical education research journals is academic medicine. I've put in parentheses the impact factor. These impact factors are nothing when you think about big journals like New England Journal and JAM, which have impact factors of 100 or 27, 30, and then you have our top medical education journal that has an impact factor of 3.5, and that's often based on the volume of readership they have. But academic medicine is a big one. Advances in Health Sciences Education is another big journal. BMC Medical Education, Clinical Teacher, Journal of Continuing Education in the Health Professions, more interdisciplinary, and then the big one that's now maybe about 3 years old is the Journal of Graduate Medical Education, which has a ton of interesting articles each quarter that focus on GME training and GME medical education outcomes. And then there are a few more listed there. The idea of your specialty journal is also great. You could look at a specialty journal in your area of interest and you'll notice that they have education articles, and that's because there's more and more of a push to be broader than just sort of the clinical outcomes. There's this idea of how do you train people better, how do you make people better providers of patients, how do you streamline effectively, deal with really important topics that are public health topics and train people on them. So the specialty journals are expanding. And then, JAMA has an annual medical education issue, incredibly hard to get into, very much pushes that boundary of the top of Kirkpatrick's pyramid. They don't really like to look at articles that don't have some area. New England Journal publishes a couple of articles. The big IPASS collaborative, which some of you might have read last year, was this, I think it was almost 9 or 10 institutions that did this huge handoff bundle. It was like a bundled program of, sort of resident training and buttons and changes in the floors, led by these Harvard researchers. Actually, Dr. Phil Landrigan, who's our global health dean, his son was the sort of lead author on this. it walked its way into the New England Journal of Medicine because it was such a complicated but such a beautifully designed study that was educationally based. And then MedEd Portal, which we'll talk about in a minute. And so MedEd Portal comes from the Association of American Medical Colleges. It's an online publication service that's free, open, peer-reviewed, and self-contained. So it's like a repository of peer-reviewed products, which is really great. So let's say you want to start, you're thinking about having teaching high-value, cost-conscious care, and you're like, I don't necessarily want to rebuild a whole curriculum on that. I'm really interested in that as a topic for, say, junior medical students. What's out there? Go right into MedEd Portal, log in, type in high-value care, and all the products that have been submitted there that have been accepted will be there. Some of those products might be literally the whole slide set and a faculty guide, forms that a student might fill out, a quiz to give them. It's like the entire curriculum for that. Let's say you're interested in like an OSTE for, you're saying an OSCE and you want them to do the musculoskeletal exam of the knee. You type in knee exam, you might find an OSCE station that's already built with the checklist items and the training for the standardized patient. So it's a great resource. Before you start building something you want to do, you might want to start looking to see what's out there. What's nice of this is that all the authors there want to be contacted. So you could be like, oh my God, this is exactly what I was thinking. This person's doing it at the University of Chicago. Maybe I could be a site and we could collaborate and test it out here and there. So it's a wonderful, wonderful place to look for stuff, but also to publish your stuff. So what do they publish? They publish workshops, virtual patient cases if you build them, a tutorial, standardized patient cases, lab guides, videos, simulation cases. They're looking for all sorts of materials to help educate and assess and evaluate. That's what's lovely about them. So, you know, what's a publishable unit to them? This concept of, you know, do they just take anything? The answer is no. In terms of something that they would consider content insufficient would be if you gave them a syllabus. You just handed them some syllabus and said, this is my syllabus for whatever. They don't want that. They don't want lecture slides without a guide. So if you had lecture slides, you say, this is the concept of what I was teaching, and here's how the lecture slides would be used. Here's how the facilitator would interrupt, stop. This is what they would do next. It would be a 10-minute discussion. They'd work in pairs. You'd give them a facilitator's guide. Or just a reference list. You're like, Residency to Curricular, here's my reference list. They don't want that. Now, content excessive is you say, here's my entire course. The course was 16 modules. Here's all the module material. Here's all the slides. They don't want, you know, sort of a behemoth of a college course. Or you said, oh my God, I've developed this lovely online textbook and I'm going to send them all that stuff. No. They're looking for these things that are sort of self-contained units that can be used by anyone like us to do that work in our place or use that product. And what is also really important about it is that it's peer-reviewed. So when you submit it to them, it goes through a peer review process. And once it's accepted, it goes on your CV as a peer-reviewed publication. So that's what's nice. It doesn't have to be that I ran it on the whole class. I waited for all the data to come through. They do want a little assessment data, but maybe you piloted it with 15 residents or 20 students, and that would be adequate for MedEd Portal. So it's a very good resource to think about publishing in. So from that, in terms of thinking of where to present and where to publish, I wanted to sort of move into this concept that often we talk about, which is, what about any tips for writing? It can be something that many of us feel really comfortable with. Sometimes it can be very, very hard to do. And I love this work from Bill McGahey at Northwestern. His interest is in sort of thinking about how we as academics, with so many competing demands, taking care of patients, doing research, administration, you know, it's just like your life gets busier and busier. How does one develop some sort of habits of practice around writing? And he talks about this concept of blocking out time to write, and he very clearly says it's not about blocking out 6 hours, which is unrealistic, and I'm never going to do it. But it's this concept of saying, in a 2-week block, I'm going to look for one hour time slot in my 2 weeks, where it's going to be, I'm not going to let anything sort of come in there. I'm going to save that 1 hour, and I'm going to turn off my emails so they're not popping up in shadow format on the screen. And I'm going to block off my phone, and that's the point at which I'm going to write. And I'm not going to say to myself, I have to come up with a page. I might write a paragraph. I might write just what my objectives are. I might write like 2 lines of my background, but I'm going to spend that hour and I'm going to block it out. And that really builds on the work of David Sackett, who did all this work in EBM, the sort of guru of EBM, who talks about how that was one of the defining features of his very productive career, was this idea of blocking out a protected piece of time that's realistic and never, ever touching that. It was sort of sacred to him. To think about the structure of your manuscript, to say, okay, so I'm really interested in the Journal of Graduate Medical Education, but look, all their articles have a 2,000 word limit. don't allow more than 2 tables, or this is the way the structure of most of those articles are going to be, because that helps you not think about, I'm going to write a huge manuscript and then spend 6 weeks kind of cutting it down from like a thesis to something smaller. To create an outline is one of his biggest tips. He's a strong believer in saying that you constantly work with your mentor, sending back the outline 100 times. So it might start with just the sort of subheadings of the categories, then what your bullets would be in that category, going back and forth, and literally it's all outline, no connector words, no like linking it. Your outline becomes so fleshed out with your mentor or the person who's your mentor author, that literally the whole thing is an outline form, and then you just pull it together. As opposed to saying, here's my general outline, let me start writing the whole thing, and then spending days and days and weeks and months sort of chopping it and like going back and forth with the revisions. And I was telling the group at Macy this year, I tried this with one of my most recent articles with someone I was working with, and it took a lot out of me because it was not intuitive to me to do it that way. It took a lot out of me, but literally at the end when we put it together, it was like so fast. We did not have to go back and be like, what citation, where did I move that? It was because we had fleshed out all our questions before writing it till we got to that perfect outline, and then we just sort of sealed the deal. And then so you create the outline, then complete the section, and then just get this feedback on the draft. But then you're not getting this first eye on like, wait, I wouldn't organize it like this, and why would you put this here? It's all that has happened before. He talks about this concept of how might one become a successful scholar. That you can have things that are attributes that may be more particular to you as a person. That you might be very passionate about something or very inspired by your convictions. But then you also have to do other things. You have to be able to manage your time effectively and try to set and meet deadlines, just like you do in your other parts of your work. And then the part in medical education that is actually very, very cool is that you will develop, as you go along, this really great community of scholars and peers, right? So that it becomes this community of scholars and peers that are interested in the same areas you are, that introduce you to friends who might be interested in the same topic you are. The next thing you're doing, you're developing a project with somebody else. It becomes a partnership. You will see that more and more medical education journals are pushing for multi-site studies. They do not want the simplest limitation to begin with. This is a single center study. They want some generalizability, so that having friends and colleagues is a great way to call up someone and say, do you want to try it there? Because we can run it simultaneously at another place. And then the scholar community that you get through participating in professional organizations. So this concept of how might one become successful is not sort of all internal and what I think about myself and how strong a conviction I have. It's this idea of sort of this broad community of people that then become sort of partners with you. The concept of not only having that community, having those attributes, working closely with mentors to try and keep up with the literature. The literature is impossibly hard to keep up with already in the field of our clinical practice. But you could take some very landmark journals that you are interested in, say academic medicine, and maybe your specialty journal if they publish education, and you can have a table of contents sent to you every month, so you can just quickly glance through them. And then it is like, as with all research, it's like we get a rejection of a manuscript and you're like, I'm throwing my hands in the air, I'm sort of done, this project was kind of useless, I'm not doing it again. But it really can be very, very formative, and there are more and more journals where reviewers are giving very, very pointed and good feedback, like really good feedback. And some of the journals that I've been involved with are very kind of almost saying to reviewers that if you can't provide a very granular and good amount of feedback, then this is not the journal to review for. So people get very good feedback. And then a sort of pet peeve of mine is this concept of developing a scholarship agenda. As educators, we say yes to everything. We're like, sure, I'll teach them and I'll do that. And of course, I'll say yes to that. And you're inviting me over here and I'll do that. And we do tons of yes, which works really well early in your career as you're trying to learn what it is in this broad domain that's particular interest to you. But my strong suggestion would be that after you develop some breadth, is to think about what really gives you a lot of pleasure and develop depth. So instead of saying yes to every single thing, you might say, what I'm really interested in is sort of technical skill development in one particular area, and that's what I'm really obsessed with. Is it like, how do they learn it? How do people become mastery learn at it? How do they, teach other people that skill? Like, develop some area of depth and really focus in on that, so that when you look at your portfolio at the end, someone can really see where you went and the sort of arc of your thinking, as opposed to like, oh my God, you've said yes to 100 million things and there's no cohesion to it, which is something that absolutely affected me in my career because I had all over the place when I started, and then you have to slowly sort of finesse it. And we have in medical education much less sort of very formal mentorship on, as investigators often do, right? Where it's like sort of there's awards from the NIH for mentorship, and how they mentor matters in terms of their research. In education, there's more informal mentoring and mentoring that you pick, but you also have to then be accountable in terms of this depth. So just briefly, like how do you take everything you do and how does it translate into something that you'll put together when you apply for a job? So the Association of American Medical Colleges, they have a group on educational affairs, and they took a lot of the stuff from Boyer and Glassick, and they said, well, all these academic institutions are measuring educators. They're putting value on them. When they come in, they're saying you come in as an instructor and you come in as an assistant professor, but you come in as an associate professor. How are they doing that? And on what basis are they making those decisions? When for investigators, there were very clear ways. They'd say, okay, so you've been mentored for 3 years, you have 16 articles, and now you're independently funded with, ABC, KY, whatever, grant. But that is not a reality for educators. So how are they doing that? So this group really tried to say, what are the core elements of educational scholarship that you can be measured on? And then how might you document those so that the language across institutions becomes more clear and formal for us as educators? And so they sort of put it into 5 activities: the categories of teaching, like how much you as an educator do direct teaching, the bucket of curriculum development. Many of you will be advising and mentoring junior trainees, students, colleagues. What roles do you have in educational leadership and administration? And then in terms of learner assessment, you might be building assessment activities for your learners depending on what role you have. So those were the 5 categories, and they said that for each of those categories, there were 2 documentation standards that you would put together. The documentation standards showing evidence of excellence in that category and how you engage with the educational community in that activity. So what does excellence mean? There's a quantity, right? There's a concept of within the bucket of teaching, what are the types and frequencies of teaching activities that I play a role in? And what's the quality evidence? Like, what's my rating as an educator? And what feedback have I gotten as an educator? But then the concept of that engagement with the community is how, in the bucket of teaching, for example, how do I take what's known about teaching and incorporate it into the way I teach? And then how does what I teach really contribute to the field? Like, what scholarship have I done in that area? So they take each of those buckets and say, you have to provide evidence of excellence and evidence of engagement with the community. So what this would map out as is you would take your activity, what your role is, and you say, what's the evidence of quantity? What's the evidence of quality? What's the evidence of engagement with the community for each of those activities on those 5 categories? And then, of course, the types of evidence might vary by category. And where this plays a role is in portfolios. You will develop an educational portfolio. Most jobs, when you first start, might not ask you for one, but if you're taking a role as an educator, will certainly expect you to develop one and then provide that and have it sort of active, just as you have a very sort of up-to-date CV. The concept of having a portfolio that's up-to-date in these buckets with this common language then means that when you're finishing one job and looking for another, you can send your portfolio right to the next place, and they're going to be like, I get exactly what you're doing as an educator. So you won't be like scurrying around at the last minute, because most of them are going to say, your CV is one thing, but we want an educator portfolio. And I think that's my last slide. So I am happy to take questions and clarify anything that you have. Questions about? Andy, can
Answered all questions, I guess. So 2 things I would say that relate to what Dr. Karani was talking about. So one, the JAMA Medical Education Edition was like a month ago. I would definitely take a look at it. I think it's a good sort of aspirational target for the kind of work we do. The other piece is I would go the listing of all the journals. I would just subscribe to the table of contents to a few of them. This isn't like Medium where they're going to send you 4 emails a week. These are monthly or quarterly, so they're not going to crowd your inbox. If you're busy, just delete them. But I think subscribing to ones of different impact factors will give you a sense of what work is out there. So some will be very intimidating, when I read academic medicine, it's very intimidating work. But some, lower down, you're like, oh, I could do this kind of thing. So sort of get a sense of what exists out there in terms of the research. And the second, so the Fitzpatrick sort of triangle pyramid. I feel like we think about that a lot. So I would think about that a lot in the work you're doing, is trying to like target multiple levels. And I think in talking to a few people, I think you don't want to just target like one level. Your goal is to sort of hit all of them. Even reaction data sort of at the bottom is like a useful first step, and it's easiest to get. Sometimes it can sustain momentum internally. Like if you like have a project, it's gonna take a while to get like good data on like impact, but having like popularity is gonna make you want to keep doing the work and make your project keep going. And I think I've told this example to a few people. Like I built a curriculum for homeless education for the medical students. So like built it, we put it in place, and then the core trajectory changed like a week after we started doing it. You know. So once they kind of reevaluated the curriculum, they were sort of wondering why this piece was here and whether they really needed it. So I think me having a little bit of reaction data actually sort of saved the project. So I could say, I can't prove to you anything. I can show you that like 90% of students preferred having a session on homeless health as part of the ambulatory training. So again, it can be really helpful in sustaining your project. So I think about targeting sort of multiple levels.
Dr. J was going to cut your program.
No, it's Dr. Russo. She
Just
took over, yeah.
And he's like, wait, stop.
Like, please. Any other last questions you guys have while we have Dr. Karani here?
Cool.